called Population Services Kenya. We have as a number of programs, a lot of them around SRHR, and it is in that capacity that I got the opportunity to moderate the session today. Thank you very, very much. I am a tiny little girl. I'm not a girl, I'm just short, really short. I think that's for the audiences who have visual impairments. Let me see, I think I'm brown or chocolate, I don't know how I think. Brown hair, I don't wear spectacles. I'm wearing a dress that's brown and blue. It's really a brown affair today, with a blue sweater and brown wedges. Great. So I work at the NGO, like I mentioned. For the past 6 years, Population Services Kenya was funded by the UK government to support the largest RH program across 19 counties in Kenya. And one of our innovations was actually inclusivity, making sure that for the first time within Kenya, we were training healthcare providers to support the information and service provision for people with disabilities. These are women with disabilities in marginalized areas, and we did quite a number of work from there. So this afternoon, we'll be looking at a session around SRHR and access to information and education. And with me, I have a wonderful, wonderful panel. I'll start at the very end with Deborah. You'll introduce yourselves and then come this way. Thank you.
Good afternoon, everyone. So my name is Deborah Maboya. I am coming from an organization called Pahe, based in Tanzania. And at Pahe, we use the power of storytelling and media technology to create educational content, which are in form of animation, comics, and radio dramas. But apart from that, we also have been able to develop an application that helps girls with disability to be able to access sexual reproductive health information. Thank you.
Good afternoon, everyone. My name is Barbara Ndolo. Just to begin by describing myself, I'm wearing spectacles, between short and fairly tall. I'm wearing a jumpsuit with patches of black and gray. I'm also wearing a kimono. In the morning when I was leaving the house, I thought the kimono is blue, but my colleague told me this morning that it is green. I hope it's true. Yeah, so I work for an organization called Cheshire Disability Services Kenya. And in Cheshire, we implement around 4 thematic areas: inclusive education, socioeconomic empowerment, health, and rehabilitation. And the 4th one is strengthening capacity of organization to be able to implement around those 3 thematic areas. We also work through partner organization, and we currently work with over 40 partner organizations across 33 counties. At CDSK, I'm in charge of a program called Mekwe. It's a consortium program implemented in the global north and south. We implement in 5 countries across East and Southern Africa, and the program is about sexual reproductive health and rights for all. Thank you.
Hello, good afternoon. So my name is Nina Efedi Okoroafor. I'm Ghanaian, although it's a Nigerian name. So I'll describe myself. They tell me what I'm wearing is multicolored, but it has predominantly orange in it. So yeah, with other colors. I have sister locks on my hair, and it's intricately woven on the top. It's what? Shoulder length? Okay. So I'm Ghanaian, like I said, and I am the youth chairperson of African Union of the Blind. In Ghana, I work very closely with Ghana Blind Union and Ghana Federation of Disability Organizations, mostly around capacity building, advocacy for persons with disabilities, but again, very closely with women and girls with disabilities and their sexual reproductive health rights. I also work as a social development officer, and I help rehabilitate persons with disabilities. I'm very excited here to talk about sexual reproductive health rights. Thank you.
Okay, good afternoon, everybody. My name is Oluwa Enitan Sophie. I'm from Lagos, Nigeria. Making an attempt to describe myself, I am dark. I have African braids on with curls. I have glasses on, black, and I have this African print, Adire from Ogun State, Nigeria. I am the founder of Natinee Empowerment for Sustainable Impact Initiative. And at Natinee, what we do is we advocate for inclusion, gender and disability rights. I like to describe myself as a development practitioner. I studied law as a second degree to help my advocacy for sexual reproductive health and gender rights. I also like to say that I preach the gospel of sexual reproductive health, and I'm happy to be on this panel. Thank you.
Thank you very much. And we'll actually start with you. And I like the whole discussion already around advocacy and self-empowerment. So let me see. So which one will you take first? I like what you mentioned, that your background is actually legal. So maybe mention to us from your understanding, what do you see are the primary barriers that women with disabilities face when it comes to them accessing accurate and accessible SRH information?
Okay, thank you so much. And as a lawyer, I want to speak from the Nigerian context of what I know. The thing is, in Africa, we have a lot of laws. Most of these are treaties and conventions. Many of them are not homegrown. Many of them are like copy and paste. We have our leaders just go into these conferences and then they say, oh, the eyes have it, you sign this thing, without considering the realities on ground to say that we are signing this. For instance, there's a Disability Rights Act in Nigeria, and also we have the Violence Against Persons Prohibition Act, 2015. But the truth is, how does the common man feel these laws that we have? And these are kind of like the barriers. We work with persons with disabilities, and you find out that a person with disability has just been abused, or a person with disability wants to access reproductive health services. Let's talk about somebody who is out of hearing deaf. How would they get sign language interpreters to help them pass their message across? Somebody who is non-verbal. The caregivers, the service providers, do they really have this knowledge? And I think those are part of the barriers, because if this knowledge is not there, the empowerment for the primary caregivers and service providers, then there's a problem. There's a lacuna that we need to work with. And that's one of the reasons why we look at disability awareness and empowerment in Natinee. Thank you.
Thank you very much. And just from a medical point of view, health knowledge tends to be a bit complex. It's not as common. The other things, the other day my son had his birthday and he wanted us to bake a cake, and I didn't know how to bake a chocolate vanilla. All I needed to do was just get into YouTube and I'd get a pretty good recipe. But that's not the same when it comes to health information. If you're going to get accurate information, if you're going to get information that is going to adapt to your body as a woman, you want to get it from a person who's qualified. And as you're speaking, I just thought, to what extent really, you mentioned about policies and how African countries tend to just copy and paste. Because I thought about medical school. I graduated in 2006. I do not remember a single session where we were taught or guided on how to work with someone who's living with a disability. So then it means systematically the university has produced a lot of us who now need an additional funding, an additional grant to really understand what it takes to offer accurate SRHR information. Thank you so much for that. So move to Enitan. So Nina, sorry. So Nina, talk to us about stigma and cultural barriers. So in your opinion, how do communities and families and institutional stigmas restrict access? And might you think of anything that you consider an effective intervention?
Okay, thank you very much. So socioculturally, sex is not something you talk about very freely out there, right? Even without disabilities, sex should be spoken of only in the bedrooms, very quiet, under wraps. But here, these are people with disabilities who we are expecting to be reserved and pinned, and are saying they want to do what? Have sex freely, and they want to express it. Well, it's going to be met with a lot of reservations. You shouldn't be having sex. You shouldn't be putting yourself in the way. You shouldn't allow anybody, as a blind woman, you shouldn't allow anybody get you pregnant. It's not fair. You will suffer. And they make all these determinations for us, forgetting that we have sexual reproductive health right is first a right for us to enjoy as human beings. And so they really would deny us based on social cultural angles. You shouldn't be having sex, you shouldn't be reproducing. What if your child also gets the disability you have? And it's all mainly because, people fear what they do not understand.
Absolutely.
And so they use that fear to restrict us too. Now, guess what that is going to in turn do to us? We would be practicing unsafe sexual practices because we have been told to keep our sexual urges to ourselves and not express it so as to get help. So now, what would I suggest as ways to help curb these barriers? You mentioned that in medical school you were not being taught. I have been in a number of sessions every year. I see not less than 100 medical students from the University of Ghana on disability sensitivity. And sexual reproductive health is one of my baby child. I asked them, if someone as tall as this walks into your office and says, "Doctor, I need family planning," what do you do? And the very first reaction is, they all laugh. "Oh, but she's too short. Oh, she's a child." But you did not conduct any form of assessment. How do you know what age or the susceptibility of the body? And so our medical personnel, from the doctors to the nurses, need to be trained right from school, need to be trained from all levels. The pharmacists, everybody needs to understand that it is a right of every human being, much more persons with disabilities too, to get the needed treatment and information and attention they will need so they can protect themselves and practice safe sex. I'll stop for here.
Thank you. Thank you very much, Nina. So yes, in fact, as you're mentioning, I remembered that for most people, when you visit a facility, you'll end up a health facility. You interact with a lot of people. There's a gateman who you interact with. You'll probably meet a triage nurse. Then you'll end up meeting your clinician at one point. Then you'll get to the pharmacist. So the disability education and sensitivity doesn't just happen with the person. It's not just necessarily with the person who's taking your clinical history and making a determination. It actually should go across, because even the pharmacist should be able to guide you on how to take your medication well, so that you don't end up either with drugs that have been mixed with another. How do you report when you feel like you're having maybe some adverse drug reactions? So thank you, Nina, for really highlighting the importance of education across the entire stream. So we'll move on to Barbara. I think, Barbara, you mentioned an app that your organization is working. Is it you or Deborah? Okay, so then, so what we'll do with Barbara will talk to us about inclusive program design. So how do you, from your organization, from experience, please share with us some examples of inclusive and effective SRHR programs.
Thank you so much, Charlotte. So for us, we look at inclusion, not just from an individual dimension. We look at a person from a multifaceted dimensions, where we look at disability, we also look at your gender, and we look at the barriers that are compounding disabilities and how this impedes your access to sexual reproductive health and rights. So for the program that I implement, we have tried to design the program in a way that it is inclusive. And for it being inclusive, first of all, you have to look at your principles and values that bind you, pushes you towards the goal. We are guided by the principle of universal design, where everybody, a wide range of persons, are able to access sexual reproductive health and rights services and also information, including persons with disability when they need it, and they can access it from wherever they are. So we work at different levels. We advocate for inclusive policies. We also advocate for inclusive health services at the facilities. And we also do what we call budget advocacy, public budget advocacy. So in advocating for public budget advocacy, because most of this decision, most of what informs planning comes from also allocation. And one of the things that we're trying to do is to advocate for intersectional budgeting by the government. What do I mean by intersectional? We want you to plan for persons with disability as far as SRH is concerned. In most cases, we have seen different programs coming up, but while this program do not cater for the needs of persons with disability, I once visited a facility, and in this facility, we were doing audits. And some of the stories that we have been able to hear are stories of, for instance, a woman trying to access family planning. And this woman is not able to, this is a woman with physical disability, amputated from both ends. And this is a woman who has gone for Implanon, or let me say just implant. So remember, when they have to administer implant, it has to be placed at the hands, right? Yes. But this is a woman who does not have both hands. So do we have a range of, or this compromises her choices of contraceptives, right? So then how do we devise our programs for them to be inclusive and to cater for all persons with disabilities? So we have been training service providers on disability inclusion. We have also been doing engaging young persons through safe spaces. And with these safe spaces, we are trying to empower them to take control of their lives. And when you want persons with disability to take control of their lives, you first have to recognize that persons with disability are the experts of their lives. Looking around the rooms, we are talking about SRH. SRH affects adolescents and young persons most. And I want to see where young persons, conferences are inclusive enough to see more young persons from the rural areas who are with disabilities attending such conferences. We want to see equity in terms of access, and we say that even in programs, you don't just take persons with disability and bundle them together when you're planning, because this is a heterogeneous group. So how are you going to plan for the deaf as far as SRH is concerned? How are you going to plan for the deaf-blind? How are you going to plan for those with physical disabilities? Yeah, so we use an intersectional lens to look at our issues, and we have gone ahead to develop a number of tools that we use to implement. But one thing that we are really doing to ensure inclusion is ensuring that young persons are the advocate, they're the drivers of the program. And being drivers of a program, they're the key decision-making table where they sit together with directors of the different organizations in the consortium to make decisions that take place, or whatever take place in the program. And decisions that are made are actually from the young person, and their views are sought. Okay. Yes.
Thank you very much. Thank you. So we'll move to you, Deborah. Thank you. And we want you to tell us about digital platforms, digital tools. So how can we use them? How can we leverage digital technologies, digital platforms to make sure that we're expanding reach for SRHR information and education for people with disabilities?
Thank you. So at TAI, we believe that digital platform help bridge the gap between knowledge and action, but also bridging the gap between exclusion and participation. So taking an example of an OKI application, so this is the menstrual period tracking application, which we have been able to develop in partnership with UNICEF, which help young girls, including girls with disability, to be able to track their menstrual health period. Not only that, but also access sexual reproductive health information. And the beauty about OKI, we have been able to co-create it with girls. So the content inside, the features, the way the app is, are the ideas of young girls with disability. They say, this is what we want. Mm-hmm. This is the kind of information that we are missing. And the OKI itself application, you just need internet once when you are downloading it. Afterwards, you can use it without internet. So that we're trying to see how we can be able even to reach out to young people, because internet is expensive. How can we ensure that OKI application is accessible for all people? But the app itself, there is a lot of stigma when we talk about menstrual health and hygiene. These are topics that you cannot speak in a public area, especially talking about sexual reproductive health issues. But now what the OK application, it creates a space place where young girls with disability, they can be able to engage with it. And what we have been able to do is to ensure that the OK is really accessible for girls with disability. So we have features like talkback features, but also we have digital skills aspect, which were also embedded into the application, in which young girls with disability, they can learn about accessibility, how they can be able, if you're using a smartphone, how can you be able to increase and decrease the screen? So aspect like that to ensure that inclusivity is really included in this application. And apart from the OK application itself, I talked about the power of storytelling. So we create animations which raise awareness on the challenges that young people with disability are encountering within our community, especially in accessing sexual reproductive health information. And in creating this process, this content, to ensure that we put the young girls with disability at the center of sharing their stories. We go to the community, we understand what are the challenges, what are the needs, because at the end of the day, we want to inspire change within our community. And with the OK application, we have been able to engage with over 6,000 users, but also directly impact over 10,000 girls, including girls with disability in Tanzania. And this, we are just getting started. We are currently working on developing sign language videos that can also be embedded in the application. But also we want to ensure that the young girls with disability, they can be able to enjoy while using the OK application. We normally say OK app is for girls by girls, period.
Thank you, thank you. Thank you so much, Deborah. That is so insightful. I feel like downloading it already, so as soon as we're done, I'll be on it already. Thank you. So I want us to come back to Barbara. And so Barbara, you mentioned the programs that you do. And something I thought about is measurement, because for the Kenyan government to plan, would need to be able to measure numbers. So tell us about your experience in how you do measurement.
So when it comes to measurements, in terms of course, one thing that we normally say in our program is we don't want, everybody is obsessed with numbers everywhere, but are we looking at the quality of the programs that we are implementing? So I always tell people, we always say that I would rather do less and obsessed. Why? So one of the things that we measure in our program is meaningful engagement of persons with disability or young persons with disability within their diversity. So, and we have a tool that we use in measuring their participation in our program. And this tool is, we call it Meaningful Youth Engagement Tool. And we administer this tool. So what we measure is, it is administered by young persons themselves, and they are able to administer it with other young persons, and they ask each other, how is our level of participation in the program? How can you rank our voices in the program? Can you rank our power to make decisions in the program? And when we also measure in terms of quantitative, are we seeing commodities? What are the commodities that are being accessed mostly by persons with disability as far as SRH commodity is concerned? And sometimes we even do audits. And some of the things that we look at is the accessibility of these facilities. Do they have ramps? Do they have signages? So those are some of the things that we look at to ensure that facilities and programs are inclusive, and even the documents that they use, the information, the kind of information. And we go further and see the engagement of OPDs. How many organizations of persons with disability are actively being engaged and their views are sought in certain programs, and even decision-making at national and county levels when it comes to governance of facilities.
Thank you very much, Barbara. Thank you. I like that you really don't want to be obsessed with numbers that don't say what's necessary, but I like how you broke it down, because then you're looking at numbers that are measuring for you what you really want to know. You're measuring for you meaningful engagement, measuring for you commodities that are preferred. I don't know whether we have anyone from the Ministry of Health, but I know the country has been having some issues with the commodities since President Trump gave the stop work order. So I don't know what will happen. In fact, I'm thinking, so we do all this, and then we talk about it, and then there's information, and then there's need for uptake, and the women get to the facilities, and now there are no commodities. So actually, I want us to come back to Nina, and then just tell us about self-advocacy and self-empowerment, because at that point, we'll need to make sure that people, women with disabilities, young girls with disabilities, are part of the voices that are advocating at that level, at the community level, so that you don't have a girl having to travel so far against so many barriers just to get the commodity. So how do we prepare young girls with disabilities to be self-empowered for self-advocacy?
Thank you very much. So to prepare young girls with disabilities, for them to know, have information about their bodies, we need to create content that helps them understand what is happening to them. Most times we recently celebrated World Menstrual Health Day, right? And most times you see videos around, this is the best way to wear your pad. Okay, do you see what I'm doing? Okay, do you see what I'm doing? And there's a blind woman in the room, and she says no, and you say, well, we'll see you later, and no one teaches her the right way to wear her pad. So she will keep doing what she thinks she knows, only to end up realizing that she's been doing it wrong all the time. But guess what? She has picked up infections because she didn't understand what to do. So we need to create inclusive content, accessible content that we can use to teach them to understand their bodies, to use the knowledge that they have gained from understanding their bodies to create boundaries so they can prevent themselves from being exploited. A lot of these girls are being exploited by people in their homes, and they can't speak against it because they don't understand what is going on with them. They can't assert and keep themselves away from those things. And yet again, they don't understand what the discharge they're getting means. Right? There's something coming out. I don't know what it means. I'm shy. I don't know who to talk to. But all the information out there is saying if there's a discharge and it's green, this is what it means. But she's not about to show someone what's the color of this discharge. Tell me what it means. And so we need to really, really pay attention to how we train them and teach them what rights they have within the information we're giving them, how they can use it as a tool to speak for themselves and then demand the services that are out there for them. So once we give them proper education and build their capacities in those ways, it makes them able to speak for themselves, be bold, and stand against discrimination. So they can then tell the nurse in the hospital who is refusing to give them a medication or is refusing to even see them exactly the implication of what she's doing. That she's denying them their, the nurse is denying this woman with disability her rights to be seen and heard and be recognized in her reproductive health rights.
Thank you. Thank you so much, Nina. Thank you. Thank you. As you spoke about that, I thought about how, I don't know, this group has a number of women represented here. And I turned 42 this year, and I still have days when I wake up and I'm thinking, I don't understand this body fully. I thought we should go this way, yet you're going this way, and I'm a medic. And still, for me, that's quite a lot to just wrap my mind around. I sometimes have discussions with my sister, and then she brings it home and says, no, women at this age and women at this age. So really really emphasizing the importance of building the capacity of this girl to even understand her body through the month, because your body changes 4 times in every month, but then every month is different from how it changed last month. So you don't have any month that's the same as last month. So each month you're looking at something. If the weather changes, you're different. If you travel, you're different. So really the importance of building capacity for girls to be able to actually have the information so that then they can advocate for themselves. So Enitan, we'll come back to you. I like this legal background thing. So I'm going to drive it a bit. So participation and policy. Participation and policy. there's this funny thing that people, I hope no one can report me about this. So there's this funny thing at the Ministry of Health when people are fighting about resources. So I think the way the seats are designed is such that at the point of meeting the PS, or is it the CS, there's, I think, spaces for 3 people. So either nutrition, immunization, or family planning, or HIV or TB. So the 3 people who usually get the seat are the ones whose agenda passes. So if nutrition, immunization, and TB program are seated, then the agenda will pass. Then everybody else will be in the media the next day. We were not represented. So the next time they'll be swapped. Then you'll see the person for TB and malaria and someone else are present. But then immunization will be in the papers. We didn't get funding. So we don't want a scenario where we are missing out on that really critical conversation. So how do we prepare young people with disabilities to be present when it really matters? And how do we participate? Because sometimes, like Nina said, sometimes people are labeled. They're labeled a particular way because they're not understood. So how do we put together a language in such a way that we can participate and be part of the policy? Thank you.
Okay, thank you so much. And then in the area of policy advocacy, I like us to look at it from the angle of DEI is like a buzzword now. And I think that more than tokenism and just the need to have somebody in the room, it's very important that we train the people that are representing us. Young persons need to know, because if you don't know, there's no way you can demand for this thing. And like the cliche that says, there's nothing for us without us. Nina just talked about the challenges a visually impaired person can face, or maybe somebody who is deaf or hard of hearing. And there's this thing around reproductive health. So I want to speak as a woman who lives with endometriosis. It took me about 10 years to get diagnosis, and I still go through a lot, just like I said, the time of the month, having flares. I really don't even know how to put some things into words. Now imagine a woman with disability, any of the clusters. It feels like you are a burden on somebody. I have invisible disabilities, but I know how much I go through every time, psychologically, mentally. So when people know, and self-advocacy is key, but how do you advocate for what you do not really know about? Or how do you advocate for something you do not even know is your right? So I think that focus group discussions, carrying everybody along, community, every voice matters. And the funny thing about this thing is our experiences, our individual experiences are different. No two person has the same body or the same experiences. But we need to ensure that we meet people where they are and not to make anybody feel like a burden. I'm a visually impaired person. If I take off my glasses, I can barely see. So like Nina was talking about the discharge. I need to wear my own glasses to see the kind of discharge it is. But what about somebody who is totally blind, who cannot see? What do we do? How do we describe it? So for our content, for our advocacy, we need to be sure that everything is inclusive. And also, these are not things we should talk about. In my own case, we had this stigma around menstruation. Now the whole world is talking about menstrual hygiene. We're talking about World Menstrual Health Day, and it feels so good. When I attended Menaki about maybe 16 years ago, it was not something we could talk about. And in my own case, it was also a bit funny because my younger sister started her period before me, and as did not come with as much drama as mine. So it feels like, you're a big girl, why are you doing so much drama? And I did not know that some years later, I would get diagnosis for endometriosis. And I feel like I could have been saved on time if the information was passed and somebody actually guided me, and not make me, because we have a lot of gaslighting. And women with disabilities already feel like, I'm a burden, because that's what the society makes you feel. You feel like you are a burden. You are not even understanding that somebody else is also going through what you're going through. So I think talking about this and normalizing this thing, understanding that there's nothing for us without us. We keep saying it, and it's more than the cliche. We have the solutions to our problems, and we need to be sure that everybody's carried along, because everybody matters. So for the policy is important.
Absolutely. Thank you. That's beautiful. A hand of applause for Enitan. Thank you very much. Thank you. So Deborah will finalize with you, then I'll check with Catherine whether we have questions from the online group. And for you, I'm going to give you the difficult one. So funding. We want to do so much. There's so much to do. We've barely scratched the surface. For the project that I was supporting, that was funded by UK Aid, which actually came to an end, we barely just got to the point of making sure that the government was including the indicators, was able to actually not only train healthcare workers, not only screen women well so that you can categorize the disabilities rightly. We barely got to the point of just getting data. We've not even gotten the data consistently, and that project is out. It's run for 6 years, they're done. Then now there's President Trump, and he said, you know what, Africa, you're on your own. And then here we are saying, okay, we have so much to do. So where do we get this funding? And how do we work in a way that anything that we do is sustainable beyond whatever funding that we'll get? Thank you.
Thank you very much. I think funding and sustainability is everybody's worst nightmare. Creating content, creating accessibility content, it takes time, it takes expertise and resources. But moreover, taking an example like maintaining an application like Oki app, you need to ensure that it is relevant, it's up to date, and it is responsive to cater the needs of young people with disability. It is also expensive. Majority of us working in NGO sectors, when the project ends, that is when the funds end, that's when the projects also end. So what do? So for me, I look at it in this perspective. I think it's really important for us to form strategic partners with the government, NGO, tech companies, private sectors coming together so that we can be able to share the cost, we can be able to share the infrastructure resources to develop solutions that are long-lasting. But also make sure young people with disability, putting them at the center of our programs, making them being advocates of addressing their solution. It also ensures the sustainability of our project and our programs beyond the funding period. But also, back to the funders and the supporters, I think it's really important to have diversified forms of funding, like unrestricted funds. Majority of funds that are dedicated to us are specifically to cater the project activities. But what about the operations cost? What about the salary? Sometimes we end up losing talents simply because we don't have the operation costs. But what if the funders and supporters can also be able to ensure that they put a stipend that is unrestricted to support the operation cost? I think that will be much helpful for us. That's it. Thank you.
Thank you, Deborah. Thank you very much. A round of applause for Deborah. She really, really fought that one. Thank you. So I don't know whether we can take a question. One or two, going once, two. Okay, you can start.
Yeah, all right. Hello. I'm Hindu, Gloria, from Uganda. Also SRHR advocate for people with disabilities to be included in the program. 4 questions, but one question for all the panelists. Then there's another one for Deborah. The first question is, I know we are all focusing on younger girls with disabilities, SRHR, but my question is, are we involving the caregivers or parents? Because remember, there are some girls with disabilities who cannot take care of themselves. For example, girls with psychosocial disabilities. There are others who do not have hands. How would they pad themselves? So the caregivers are responsible to give the care. If the parents or caregivers do not have the information, also the girls with disabilities could go through challenges. We need to think about that. Then to Deborah, about the app. You remember, some people do not have the phones. And information is in the app. Then how would they access? They cannot afford phones and also internet, but they need the information. How would they get this information? And then the other, let me just check my phone here. And also, I have a question. If there is information, and I have read, I have a burning question. Is there a provision in the app to ask a question? And then lastly, some youth with disabilities who have not been to school, they're not able to read. Yes, you said that you're planning to put sign language, which is good. How about those with physical disabilities who are not able to read English? So how would the app, is it only targeting the English users or also those with local language? Thank you so much.
All right, thank you. That is very well put. So Deborah, so first of all, I'm informed we're way into the time segment for the next session, so we'll only take that one question. Take what you can, and then I'll wrap it up.
Okay, just quick. First and foremost, the application it is in Swahili. So it caters the needs of Tanzania people. So it is not, so the girls can be able to decide if they opt English or Swahili, but specifically the app is in Swahili. In terms of the ones who do not have smartphone, we do peer-to-peer education workshops. So we go to the villages. We engage workshop with the girls, so to ensure that we leave no one behind. Even if they don't have smartphone, but through our facilitation, engagement, and dialogues, they are able actually to be able to get the information on SRH. And I think the other one was, I missed it. Yes, in terms of caregivers, yes. So caregiver, I'll give an example for the animation aspect that we create. So we normally say our creation fall in a human-centered design, that we don't create story from our tables. We go to the community that we serve. So specifically on our animation on inclusivity, we work direct with the healthcare providers, the rehabilitation centers, especially for children, for instance, who have autism. They cannot speak for themselves. So we work with the parents to help us ensure that the stories that we create, the information that we share, it's really inclusive and it caters the need for those who cannot be helped. Thank you.
All right, thank you. Kathy is motioning me to take one.
Yes, thank you. We have a question from our watch party from the Cindy Bliss Foundation in Cameroon. They're asking, what are the strategies we can use to get funds for the SRHR, and how well will we get the information to the OKI app, and how accessible is the app? And also, what other countries can use this app? Thank you.
All right, so a lot of questions for you, Deborah. Seems like the app is actually quite a seller today. So I'll let you say 2 sentences, and then we'll see how to network after our session so we can answer the rest of the stage.
Yes, I think I'll answer like how can the apps be accessible. So the OK app is not only in Tanzania, it's in more than 6 countries. In Kenya, there is an OK app. I'm happy when maybe perhaps after this session to connect you to our focal person who is working in implementing OK Kenya. Yeah.
Thank you. Thank you very much. Another very final round of applause for my able panelists. They've done an amazing job. Thank you, ladies. It's such an honor for me to be with you this afternoon. So we'll be here today till the end of the conference. So in case you have questions for us, kindly just meet us off stage and we'll be able to say something. So we'll get a final remark for a 30-second each. For my ladies here, starting with Enitan. Thank you.
Okay, so for me, I'll just say that I know a lot of us are working on inclusion. We are looking at technology and all that. But I'd say in all of our programming, please let us ensure that we include sexual reproductive health rights for young women and even men with disabilities. Because if we do not, and then people pick up infections or people have diseases that are preventable, most of our implementation can just come to naught if we do not. So there's nothing for us without us. Please ensure that you watch out for sexual reproductive health. Thank you.
Thank you very much, Enitan. Just pass it to Nina. Yes, Nina.
Thank you. So my final words would be looking at promoting SRHR for persons with disabilities as a way of ensuring that we are really heard in our societies. When we are healthy sexually, we are healthy psychologically, we are healthy in our bodies, and we'll be able to contribute to our societies. We'll be able to speak for ourselves. We'll be able to set our own boundaries. We'll be able to assert ourselves and promote human rights for persons with disabilities.
Thank you.
Thank you. Mine, I'm going to really emphasize on the systems of power that impedes participation. And just to say that in every ecosystem, there are power dynamics. And your position in the position, the position in the hierarchy of power depends with the identity. Remember, somebody could be having a disability and also is a woman. And this means that you keep being pushed further to the margin, and this prevents your access to SRH. So when we go back to our program, can we really try to deconstruct these systems of power that prevent women with disabilities from accessing sexual reproductive health and rights?
Thank you, Barbara.
Yes, I think for me, a quick one, I think inclusive SRHR, I think it should start from the family level because there is where the stigma begins. I think parents government, the community members should come together and really be able to ensure that we promote access on sexual reproductive health to people living with disabilities so that we can have an inclusive society. Thank you.
Thank you very much. Wow. Thank you. So I look forward to seeing you guys next year. And our session next is going to be the whole day because we have so much to say and we haven't gotten enough time. So please arrange for us our own whole day for next year. Catherine and team from Enable, thank you very much and have a good afternoon, everybody.